All right, welcome, wonderful students, to palliative and end of life care. So, this information is going to be important to know for NCLEX, for HESI, for Block 1, for your exams, and just to provide really good care for your patients who have a serious illness and or who are it's actually end of life. So we're going to discuss patients who are palliative, meaning they have a serious condition that they're getting curative treatments for, or end of life, where they opt to sign on to hospice and be comfortable at end of life. Interdisciplinary collaboration, so multiple people working on the patient's goals for their care, is considered palliative care. It's a comprehensive management, psychosocial, spiritual, emotional, physical, cultural, and it's to enhance the quality of life for any person with advanced illness. That is palliative care, right? So it's appropriate for any patient at any age and at any state of a serious illness, even while pursuing disease-directive curative therapies, extending their illness, whatever that looks like, right? And so, again, this is the definition of palliative care, right? So you might have a patient with chronic illness that is part of the palliative team. Excuse me. Dying in America, improving quality and honoring individual preferences near end of life is one of the IOM's, or Institute of Medicine's, goals that was started back in 2014 and is still widely used today. So it was an initiative to improve end of life care for patients and their families, right? So again, it was ensuring that it was widespread access to end of life care, and it was timely access for everybody for end of life care. It covers hospice coverage. If a patient has 6 months or less of life, they could sign on to hospice services, and provided comprehensive care, not comprehensive, but thorough care. Remember, comprehensive is 24 hours in a hospital. It doesn't provide that, but what it does is provide multidisciplinary team members to come in and help care and manage the patient's end of life with the patient and family wherever that patient resides. So if they live in the home, the nurse, social worker, CNA, chaplain, etc., come to the patient and take care of them, right? Manage their meds, manage their pain, anxiety, disease processes, all of it, right? And this again is for end of life. So a lot of focus is placed on advanced care planning, getting all of the patient's goals and advanced directives in place before actual end of life. A lot of education surrounding what to expect at end of life, pain management, anxiety management, respiratory management, all of those things. And then, of course, doing lots of education across the communities and allowing, just letting people know what's available to them as far as the IOM's initiative. Institution-based palliative care, again, is at regulating and managing chronic serious illness with patients. So most common patients are often older individuals, right? Again, with serious illnesses other than cancers. So you're looking at, and they typically have a full code, right? They're typically full code, the palliative patients who are on palliative. So again, you're looking at like chronic serious illnesses like ALS or, heart failure, those kinds of things, right? And again, we take an interdisciplinary approach to managing symptoms, respiratory and pain management, anxiety, and psychosocial, cultural, spiritual, all of these, any kind of distresses or situations going on in the patient's life that we can help work on to make the patients quality of life better, right? So, again, it's provided on an outpatient basis where the patient lives. So if they live in an ambulatory setting, or if they live in a skilled nursing facility, group home, or in their own home, their own home, right? So again, we provide these services to support the patient and families, maybe who are not ready for hospice yet, because they want to seek aggressive treatment for their cancer or their heart failure or whatever's happening with them, right? But they're still sick enough where they can use the help, the more hands-on help, right? Again, community-based palliative care are home-based primary care. It is becoming more and more popular because they specialize in areas where they can manage symptoms more effectively and provide more hands-on support, right? Which has shown to decrease rehospitalizations, decrease exacerbations of patients' conditions. It improves quality of life, and all of this is covered due to the Affordable Care Act, right? It's all covered and paid for, so the patient doesn't have to pay for that. Families don't have to pay for it, so it's a wonderful thing. Same thing with hospice care. That's also paid for by the government. All hospice care is palliative care, but obviously all palliative care is not hospice care. Make sure you know the difference between the two, palliative and hospice care, okay? Hospice care is literally when the patient has 6 months or less, they get certified for hospice care. If they have a disease process that is limiting life of 6 months or less, and the focus of that care is quality of life over extending the life, right? So we approach the patients with a realistic, emotional, social, spiritual, financial, all of these things to get them ready, one, to be prepared to die, but more importantly, two, to live each day pain-free, anxiety-free, as much enjoyment as they possibly can with the time that they have left on earth, right? And it's important to note that while the program pays for 6 months or less, there are patients who get recertified when that time is up. And if they're still deemed appropriate, in other words, it's expected they'll only live another 6 months, then they requalify for hospice and continue on services. We actually have some patients who have graduated off of hospice, meaning that they got better, right? And they moved on and came off hospice. And we also have patients who, we think it's going to be 6 months or less, and then they actually live a year and a half. But we recert them every 6 months and keep them on service if in fact they are still declining and still need our help. For patients to sign on to hospice, they must acknowledge that they're dying and that death is expected in 6 months or less. They must also take a quality over quantity of life, meaning that they won't seek out really aggressive measures to extend life. They're going to focus more on improving the time they have left on earth, rather than signing up for experimental programs and things like that. You can't do both. The government wants you to pick. Either you're going to be aggressive and do everything you possibly can pathway, which is fine, but then you don't sign up for hospice. That's pretty much the criteria, right? Again, patient's total care is managed by these experts that are pain management experts, anxiety management experts, system disease process, as far as end-of-life management experts and things like that. So pain and anxiety and all of these things must be managed 100%. Patient and family are viewed as one single unit of care, and we do still recognize and follow all of the HIPAA rules, but we realize that the patient, just like in the hospital, is not the only, the family is also our patient. It is more so that way with hospice patients because once the patient dies, the family is going to have bereavement services up to 18 months after that. And so they're kind of our patient too. They really are. Excuse me. We do go in patients' homes. A lot of patients want to die in their own home, understandable. And so we will provide care there, right? And then we are continually also educational experts, right? About end of life, about signs and symptoms, about all of those things, pain management, how to take the meds, and things like that, right? There are 4 levels of hospice care. We have routine home health. That's where we, again, go into the patient's homes and care for them. So, like, for example, a nurse would probably come and initially see their patient a couple times a week, do full to head to toes, manage their meds, reconcile their meds, right? Make sure that when you reconcile meds, that literally means you're going through the medications list and you're getting rid of meds they're no longer on. It's one of the things hospice does, right? Is they take patients off a lot of those polypharmacy meds that they no longer need, right? And then just keep the ones that keep the patient comfortable and live the best life that they possibly can. Then we have inpatient respite care. So every month, the family and patient get 5 days of respite care where they can go to an inpatient hospice facility and give the patient and family a break from having, the patient at home 24 hours a day. And again, that's 5 days a month. And then we have continuous care, and that literally means that it's 24 hours a day care, right? And so if the patient has some exacerbation of a condition like there's extreme pain, they're in a pain crisis or extreme respiratory distress, we can put them on continuous care and bill Medicare at the higher rate and literally go where the patient resides for where they live, right? And provide around the clock nursing care where we can call the doctors, get meds, all of those things. And then if they don't want to do, if they want us to manage them at our site, then we pull them into our unit and we put them under general inpatient care or GIP care. And then again, that's at the higher rate, but instead of taking care of them around the clock at their home, we do it at our facility at hospice. So basically the continuous care and general inpatient care is to manage acute symptoms and then get them back home, right? That's the goal of that care. There is not a building that people can go and live at where patients live until they die. That a lot of patients misunderstand that. They think that when they sign on to hospice, that they literally move to a building and for the last 6 months of their life to be cared for, and that's not the case. The case is we, the hospice people, come to them wherever they reside, right? And we can help them find a group home or a SNF, skilled nursing facility or whatever to live in, but there are no hospice agencies that just have hospice buildings that people live at till they die, per se. Most common hospice diagnoses, heart failure, clearly, cancer, lung disease like COPD, and then, of course, dementia. Tenet of the palliative and end-of-life care. Nurses must be able to assess patients' and families' responses to serious illness and support their personal, cultural, religious values, as well as their choices through the continuity of care, right? What does the patient want? Some patients, they don't want to take pain meds. They don't want to take anxiety meds. They just want to, live the best life that they can, be happy and enjoy as much as they can. Others want to be pain-free, anxiety-free. And of course, that's a goal of ours, and we get them there rather quickly for most. Sometimes it's more challenging, but we will get them there. And again, you got to remember as a nurse, when you're working with end of life patients, you really have to consider your own experiences and values about end of life and death, right? And ensure that you understand that to the extent that it doesn't impede upon your ability to do your job, right? Because it's about the patient, it's not about us, the nurse. So obviously, critical points of communication. The time of diagnoses, right? The patient's going to find out about their life-altering sometimes life-altering diagnoses. So what exactly happened to that person? You know, what exactly is going on with their illness, right? So let's say, for example, a patient finds out that they have lung cancer, right? And then the doctors decide, here are your two paths. You can, it has metastasized through the lymph system and spread to the surrounding organs. And your choices are to, sign on to hospice and be kept comfortable for the remainder of your time on earth. Or you can attempt to do chemo and radiation and or surgery. And you can try to fight the infection even though it's metastasized, right? They literally have options with their treatment, right? And then you even have further conversations with them. If they opt to do the aggressive treatment, then you just kind of let them know that, that's a, great plan. And if you do that treatment and it fails, you can always reach out to us, hospice, and we'll be happy to come and have conversations with you and get you on board at that time, right? Because there are some patients who, one, can't tolerate the chemo and radiation, or two, it doesn't work, right? They start to feel a little bit better initially, but because it's metastasized in the lymph system, they end up getting sick eventually and end up usually signing on, right? Some people, though, will get better and they will extend their life and live a great, wonderful life. And good for them, right? Good for all of them. So the effectiveness of the interventions and the effectiveness of the treatments will determine the pathway for those patients for sure. And then when they're ready, if and when they're ready, they can call hospice to come in and sign the patient on, right? So clearly our approach to communication is open-ended questions to get the most information out of our patients and to allow them time to voice their concerns, disappointment, their anger, their frustrations, because they're going to have a lot of emotions to process, and we're there to listen with an empathetic ear and open heart and to literally respond with a supporting nature. We need to be as honest as we possibly can at all times and listen very attentively so that we can hear any kind of misconceptions about end of life or pain management or anxiety management or disease management or whatever that all looks like, and give them more information when we need to, okay? You got to do really good, effective listening. So you want to say things like, I'm so sorry, and I'm so sad for your loss, and not things like, he suffered for a really long time, so it probably happened for the best. You don't ever say things like that. It doesn't matter that the patient suffered, right? The family is still going to miss them 10 million times around. So pause the video and read through this, because honestly, this is a very good document that kind of talks about the things that we have to ask, questions we have to ask, right? So we're going to ask about, do they have funeral or memorial service planning? We want to get those things down on, written down, right? In a respectful and, calm manner, right? And we're going to let them grieve the loss of their life, expectations, everything that they were planning, right? It's all been turned upside down, right? Roles of the nurse, man, you have a lot, right? So coordinating patient care. Clearly, we're still going to manage their disease process up until the end. We're going to manage their meds. We're going to manage any side effects of those meds, any side effects of the disease process. In addition to that, we're going to manage pain, anxiety, and help with the grief processing. We're going to hold family meetings many, many times. Families do not agree on end of life with what the patient wants, right? So that involves us having very good communication skills and having family meetings where there's one point of contact to address any issues or concerns that they have, whether it's concerns about the patient's disease or whether it's concerns about patient's care or whatever that looks like, right? Have one point of contact just because it makes it easier to communicate with the team. I want to make sure that everybody has access to any of the information about the plan of care. We need to know all of the patient's advance directives. And again, we're going to be managing everything from the time they sign on, not just their disease process, but yes, that is part of it too, right? In addition to all of their expectations. So back in 1990, the Patient Self-Determination Act was enforced, which literally says legally the patient has the right to select their advance advanced directives and direct exactly what type of medical care they wish to implement at end of life, right? And anytime they get to pick. Starting now, I want antibiotics, and I want to be put on a vent, and I want to have CPR done. All of those advanced directives, right? So that is the patient's, under the law, they have the right to self-determine how that looks, right? Again, symptom management is going to be all of the physical or physiological changes that occurs with severe illness and end of life, right? So pain, dyspnea or shortness of breath, impaired secretions, anorexia or cachexia, anxiety, depression, delirium. And then of course, when the patient is getting close or ending their end of life, right, time of death, we go out there as well, clean up the patient's body, call the mortuary, and then of course help the family coordinate and deal with the loss, right? Hope is a multidimensional construct that provides comfort as a person endures, end of life, life threats, personal challenges in their life. Hope gives you something to look forward to, right? Hope fostering is more like a faith, spirituality condition where, it could be relationships with loved ones or, past memories or humor that fosters this hopeful attitude, right? And then patients can have hope hindering attitudes and philosophies where, because of lack of hope, they end up isolated, which will exacerbate their pain level, which we've already talked about, right? And their discomfort. They can feel abandoned truly by family, friends, and coworkers and things like that. How do we instill hope in our patients? Well, we're going to answer questions honestly and accurately in ways that patient can fully understand, and families, right? We're going to definitely listen attentively, and we're going to support our patient's choices, right? Even when the family disagrees with it. And part of our job is to ensure that we hold conversations and educational sessions where we educate the family about the patient's choices, and we eventually get them there. It just takes time sometimes, right? But our job is to facilitate those communications between the patient and the family. Remember that we're always ensuring that we're doing this in a culturally sensitive manner and spiritual sensitive manner. So we're definitely always assessing values, preferences, beliefs, expectations, and practices from day one, and we implement them, right? We have to set aside our own assumptions and attitudes about death and dying because it's not about us, right? It's not about the nurse. Spirituality contains features of religiosity, sometimes, not always, but it does. And the two concepts, though, are not interchangeable, right? So make sure that you know the difference between the two and that you're prepared to meet the needs of your patients. Grief refers to the personal feelings that accompanies that anticipated loss or an actual loss. Mourning refers to the family, the friends, the individual, the group, or maybe even the culture's expression of grief, right? So anybody from the person themselves all the way through everybody they know, right, and deal with. That's the mourning piece. And then bereavement refers to the period of time during which mourning for a loss takes place. And people, have different bereavement periods. When my dad died, my mother, who had been with him since she was 16, he died when he was 62 from lung cancer, and she grieved severe depression for almost 8 years. She really didn't get over it for a good decade with my dad's loss, and she was never the same person again since he has passed away. It really did change her, Uncomplicated grief is to understand a few things about grief. So grief is not a linear process, meaning, 5 days you're going to be angry, and then, or 5 days you're going to be in denial, and then the next 4 you're going to be angry. It doesn't happen in a set manner, right? It happens the way it's going to happen with that person, and it could be completely jagged and all over the place, and they could be bouncing in and out of the five different stages of grief, and it could look completely different than somebody who had somebody die the week before, right? There is no right way to cope. The patient copes the best way that they can at the time, right? And we can try to help them, and we do educate them on different outlets and coping mechanisms and things that we can try to help with. Understanding, though, that because grief is not a linear process, and because it's not nice and neat, it can get messy, and that's okay. It is okay if grief is a little messy. That's fine, right? We're definitely going to promote family cohesion during grief and mourning because they need to lean on each other, right? So we're going to have those conversations, and sometimes they're pretty rough, right? Because, again, families don't always agree, and so we're going to help navigate those conversations. And we're definitely going to provide opportunities after death for social and cultural rituals to facilitate the family, friends, neighbors' acceptance of that patient dying, and as death as part of, a permanent loss, right? And so that's why culture is important to know. What kind of cultural death rituals does different cultural and religious practices do, right? Closed awareness is when the patient is not told that they are terminally ill. And there will be times when a family members don't want us to let a patient know that they're terminally ill. And we don't do that. So this is not practiced in the U.S. as a standard of care. Patients have a right to know that they are dying, and so there, like you learned in, I think it was the second week in class, there are just some secrets we don't keep, right? We can't. And so the patient has a right to know, right? Suspected awareness is when a patient suspects that they have a terminal illness, but the diagnosis has not been confirmed yet with them, right? So they haven't actually sat down with the doctor and found out that they've got this terminal illness, but their signs and symptoms are such that, they suspect that they do. Mutual pretense awareness is when everyone is aware that the patient is terminally ill, but it isn't discussed, so everybody's kind of walking around acting like everything's fine, even though every single person, including the patient, knows that patient's dying, but they're not talking about it. And then we have open awareness, where opposite, right? Everybody's openly discussing the terminal illness and working towards a comfortable end of life, and making end of life plans, but also making quality of life choices too during this time, right? So they're openly aware, and they're openly utilizing that time the best that they can, right? By enjoying life and making end of life plans so that they die the way they want to die, basically. Okay, so we have DNR orders. We've already talked about that, right? Do not resuscitate literally means that. Usually on an orange form, if the patient is residing in a home or group home or skilled nursing facility, in the home, they'll keep the orange form. We have them literally put it on their icebox or the refrigerator. Just pin it up there. So if somebody freaks out in the family and calls 911 when the patient stops breathing, when the paramedics come in, they'll need to see that orange form, or they will perform CPR, right? And then if they bring that patient back, I've seen this happen where the patient comes back and they are not happy because they were brought back and they had a DNR in place, right? So keep that orange form on the refrigerator if they live in the home. We have a place for them in the facilities and in the hospitals, right? Clearly marked. Advanced directives have anything from a living will to a proxy or a durable medical power of attorney. We want to get these in place, right? If we're going to be able to discuss medical information because of HIPAA, we need to have a patient sign the ability to speak with these individuals. If a patient wants to pick a medical power of attorney, this says that in the case when the patient can no longer make their own medical choices for themselves, they will pick an individual who can make them for them. You could have a living will that goes into in depth with, do you want antibiotics? I mean, it tailors. It can get very, very specific, or it can be higher level depending upon how you want that drawn up. I personally have in my paperwork that says I definitely want antibiotics, and I don't mind being put on a vent if up to 90 days, but if it is clear that there is no brain activity, then I have it written in my living will that I will be taken off artificial support. So no ventilators for me if my brain is dead, right? So things like that, right? Get those things in place. Then your family doesn't get to choose for you. It's what the patient says, right? There are some medical aid in dying, or what we call assisted suicide legislative states that have put legislation in place, right? Which we've heard about in the news in the last couple decades. California, Colorado, District of Columbia, Hawaii, Maine, New Jersey, New Mexico, Oregon, Vermont, and Washington. And Montana doesn't fully say it, it's okay, but they don't have anything in their current laws that says physicians aren't able to help with that, okay? So, it gets a little tricky, though, in the other states because, as you know from the media for the last couple decades, there was Kevorkian, right, was brought up on murder charges for assisting suicide. So, that's a tricky thing because you got to be real careful that you don't get any mental health patients who convince a provider to help with assisted suicide when, when it's potentially a treatable condition, right? So I think that's a fine line. I think a lot more research and a lot more information needs to go in I think there are I firmly believe that people have a right to kind of pick how they should be treated with everything in their life. It's your life, and you should be able to decide how you live it or not, right? But that's my personal opinion, and I wouldn't probably take it. I probably wouldn't opt to do it myself. However, I have cared for patients before who have said they would in the event. Now, luckily, I haven't had to deal with a patient actually doing that knowingly, right? Traveling to another state to have it done. But we'll talk more about this in class, right? It's going to open a lot of doors, and we'll have good conversations. It's definitely a hot topic, especially in the last, like I said, couple decades. Okay, last slide. Special situations for nurses at end of life. Obviously, there are a ton of ethical dilemmas because you get families who don't want to let the patient go, who want to try to, once the patient's unconscious, they want to reverse their advance directives, and now for us to listen to them about doing extraordinary things to save the patient's life, even though they said they don't want CPR, they don't want ventilators and things like that. So you end up with all these ethical dilemmas that you have to deal with at end of life. It happens, right? Or you might have a ME's case, right? A medical examiner case, because maybe you have an end of life patient and they've been given 6 months or less, but then they get up and they fall and hit their head and they die within 24 hours of having a fall. That becomes a medical examiner case because they need to determine if the fall was the cause of the death or if their critical chronic end of life disease was, right? And if it is because of the fall, now the medical examiner that works for the state has to do an investigation into that. Like it's just all of these things that we have to deal with, right? And it's tricky with the care cure dichotomy. And when I say that, I mean, like, Medicare is very specific, meaning if you want to come onto hospice, then you can't want to have, aggressive care. You can't seek out, chemo that costs $3,000 per dose or whatever that looks like. It really isn't about the money. It's more about, what path do you really want to take? Do you want to be aggressive? Wonderful. Then go be aggressive and get all of the chemo, radiation, surgery, all of those things, right? Or do you want to take a different pathway, which is not be so aggressive, par down on the meds that you're taking, become more about quality over quantity. And it is a fine line that you have to toe back and forth, right? You have to really do a lot of good interviewing of your patient to figure out truly what their goals of care are, because that's what's going to determine whether or not you do hospice or whether you do palliative, right? If you want to cure it, if that's truly their goal, then they should not go down the hospice path. They should go down the palliative path, right? And then, of course, resiliency is always a piece of it. So what we find with patients who sometimes that are given, end of life, 6 months or less, we par down on the meds, we make them comfortable, we focus all of our energy on quality of life. All of a sudden now they're doing great, right? And physically they're doing wonderful, which is really not a problem. It's just something that you should be aware of, that at end of life, because they're focused on the quality of their life, it really does sometimes extend their life a bit because they're happy and they're enjoying life. But again, it's usually within 6 to 12 months. So we just recertify them that second time around. Because they're still declining, it just isn't as quickly as they would have had they been on all those extra meds with all those extra treatments. Because remember, chemo and radiation, along with chemo and radiation comes an immune system that is compromised because it kills off our white blood cells, right? And so that's our immune system's ability to fight off infection. So patients who are doing aggressive curative care sometimes have a shorter life lifespan because they'll end up getting, a bacterial infection that will literally take over their body and it'll kill them. So that can happen. Whereas the patients who opt for quality of life and sign on to hospice, now their meds are half, literally, of what they were on before, many of which they didn't even need any longer, and they didn't know that. And now they're enjoying their life, and because they're enjoying their life and all the things from the pain lecture that you've already heard, you can see how it could extend their life for some time, right? Not inevitably, obviously. If you have a terminal illness, it's going to kill you. But if you're less stressed and you're not producing all those negative hormones and you're calmer and all of the things that we talked about in the pain lecture, then it makes sense that they're going to live a longer, way more satisfied life, right? Okay, this is the end of this chapter. Make sure you study, though, before I click off, make sure you study the hospice and palliative chapters, okay? It's pretty important information.